Hi, good morning, everyone. Welcome to another VMR session. I'm so excited to be co-discussing with Youssef today, and I'm so excited to see you all. Youssef, would you like to say a few words to everyone?
Yeah, hi. Good morning, good afternoon, everyone. I'm Youssef. I'm a resident. I'm one of the CP Solvers members. Very, very excited to be discussing with Mengyu today. Mengyu is like one of the attendings here with us, and she always gives us like these brilliant diagnoses out of the blue. So I was like so excited to this for the first time. So excited to be here. And I know Hans is here with us. Hans, do you want to like tell us about yourself, where you're from, and how
Okay.
did you find out about CP Solvers?
Okay. First of all, thank you for the opportunity to present the case in this setting. I've been watching a lot of your VMRs and I really learned a lot. And I knew of this platform because of Dr. Bettina Tenorio. She shared it in our Facebook group among Filipino IMGs. So again, I'm Hans Del Mundo. I'm an international medical graduate from the Philippines, and I like traveling. I like hiking and most especially watching anime.
Thank you so much, Hans. I know you're presenting at 11 o'clock on the other
Yes.
side of the world, so thank you so much, and we're so looking forward to your case. And we
Okay.
also have Jia scribing today and Shreya doing the teaching points. Thank you all both. Um, shall we get started then?
Okay.
Let's do it.
Okay. So for the first aliquot, this is a case of a 21-year-old male with 1 day history of abdominal pain followed by black tarry stools. I will taking a pause after this.
Yeah, Youssef, do you want to go ahead with, or would you like me to start?
Yeah, I can start. And thank you for the first aliquot. In general, just starting with the patient's age. When the patient is 21, presenting with like such a severe presentation, is presenting with black stools. And in general, when we think of black stools, we think of most likely a GI bleed, although technically it could be from the upper nasal tract, from the mouth, even like from the pulmonary tract that's swallowed. And but in general, in most cases, it localizes to the GI tract. Uh, and in a 21-year-old, I'm eager to see if they have any past medical history, any ingestions, because in general, we tend to assume that 21-year-olds are like healthy, but we do have this framework in CP solvers like bad luck, bad gene, and risky behavior, which would put patients at risk for diseases. So I'm very, very eager to know more.
Yeah, I totally agree with you, Youssef. I think we've had several cases recently for very young patient with significant presentations, and this case as well. So I think for abdominal pain, I think initially the differential sprout because you want to think of referred pain, and then go with the imaging, using the imaging to guide kind of local anatomy-based approach versus image negative abdominal pain. But then with the black stool adding to the chief complaint, I think we kind of probably localizes to the abdomen and maybe the GI tract. So like a few things that came to mind include like like we always think about the life-threatening causes like a vascular, which can be associated with GI bleed, and then perforation, obstruction. Yeah, I think it's a good start. We'll like to hear more about the patient and um, yeah, go ahead, Hans.
Okay. For the next aliquot, so I was starting with history of present illness. 5 days prior to admission, the patient had cough and colds, sore throat, without fever, and no medications were taken at that point. And then 3 days prior to admission, he noted erythematous non-pruritic rashes on his lower extremities associated with joint pain, specifically on bilateral elbows, knees, and ankles. Patient then had difficulty ambulating later that night. Then 1 day prior to admission, he had new onset diffuse abdominal pain, cramping in quality, intermittent, radiating to the back, with the rashes now progressing to the buttocks and the upper extremities, which prompted the consultation, then the admission. And then when he was admitted, he started having black tarry stools. Then 2 days after that, he then had bright red blood on his stools, and the rash progressed up to the post-auricular areas. For the review of systems, he has no fever, no weight loss, no eye redness, no nausea, no vomiting, no dyspnea, no chest pain, no dysuria, no hematuria, no seizures, or any involuntary muscle movements. For the past medical history, he has no known comorbidities, no previous surgeries, no history of dengue, and he's currently not taking any medications, no history of chronic NSAID use. For family history, type 2 diabetes mellitus on his mother, psoriasis from his paternal cousin, SLE in his also paternal cousin, colon cancer, his maternal grandmother, and no history of inflammatory bowel disease on his family. Social history, he's a college student in Quezon City, Philippines, where dengue is endemic, with no history of recent travels, no sexual history, non-smoker, no illicit drug use. All his vaccinations were up to date, and he has no known allergies. So I will be taking a pause now.
Wow, what a rich aliquot. So maybe I'll go first with this aliquot, and Youssef, I'm sure you have a lot to add. So I think now we get a rich presentation of like the syndrome is preceded with 5 days of URI symptoms, kind of a maybe viral, actually without fever, just cough and cold, which seems kind of non-specific. Then he started to develop this rash progressively from the lower extremities all the way up to the ear,
Yes.
and also joint pains that involves elbow, and so difficulty ambulation. So I think both upper and lower extremities. I'm trying to determine if it's like small joints or larger joints. I think for elbow, it's kind of like in between, but maybe more grouped to the small joints. Maybe I'll clarify more, or if honestly you have things to clarify here, like whether it's more small joints or larger joints. But like, so a few, and then this is followed by GI bleed. And yeah, so I think with this combination, like a few things just came to mind before I do more systemic approach. I think one is like a IgA vasculitis, and then like and a reactive arthritis. I think are the two things that came to mind. But I think I like to take more systemic approach, and so yeah, maybe Youssef, you have like specific approach here. I'd like to hear your thoughts as well for the rash and joint pain and the GI bleed.
Yeah, it's a very, very rich aliquot. I think just in general, to start throwing on some descriptors, this is a very acute episode. It's been only 5 days. And similar to you, Mengyu, the first thought, like my reflex type 1 thing was, oh, this is like IgA vasculitis. But to be very, very broad, under infectious causes, this could be like a disseminated infection or sequelae of an infection, like you mentioned, like an infection plus a vasculitis, or could this be a disseminated infection, although I think like less likely. Could this also be a first-time presentation of a malignancy and then now having a reaction to it, or a primary vasculitic disorder? I think just to be broad, I think this could be on the differential, but again, I think an infection with a reaction to it is right now more likely in my mind. In relation to the GI, like we're assuming GI bleed, Mengi, I wanted to pick your brain. Do you think of this could be just related to a vascular abnormality, or do you think the platelet count will also be affected in that this is also causing a trigger? Because I know the platelet count alone, general, would like could predispose to a bleed, but I'm wondering, is this just a vasculitis, or is this a superimposed component of thrombocytopenia? Because we see that the patient developed a rash. We could also on exam, I think. qualify that rash as like, is this purpuric? Is this blanching, non-blanching? Is it raised? I think that will also help us predict what we will see next and help us characterize the diagnosis further.
Yeah, thank you, Youssef. I think I also reflected while you're talking that I think the reason I was thinking like kind of a little bit jumping to the vasculitis slash like autoimmune disease was because like the very systemic acute but also systemic involvement of both like skin, GI tract, and the joints. And I agree with your thoughts about like thrombocytopenia playing a role, because like thrombocytopenia is like the likely to cause like mucosal bleeding, including GI bleed, and which could be part of the syndrome that we kind of mentioned earlier. And yeah, any other thoughts, Youssef, before we go to the next aliquot?
Oh, no, I think just when you mentioned also like skin and GI tract, also the other thought that came into my mind was cryoglobulinemia, which is also on the spectrum of like vasculitis and can cause vasculitis.
Yeah, I'd be really curious to hear the exam, to hear like what kind of rash it is and the joint distribution. And yeah, thanks so much, Hans. Look forward to the next aliquot.
Okay, I'll just clarifying some of the questions in the chat. So I'll be describing the rash now during the physical exam, and the patient doesn't have psoriasis. It's in his cousin, because his cousin has psoriasis, not him. So for the next aliquot, the vital signs, he has a slightly elevated BP of 130/70, heart rate of 85, respiratory rate of 20, temperature of 36.1 degrees Celsius, O2 saturation of 99% on room air. Yes, BMI of 25.3. For the physical exam, he is awake, alert, and oriented with anecteric sclerae, pink palpebral conjunctivae. The tonsils were not enlarged, no exudates or nor oral ulcers. The neck is supple, no jugular vein distension, has distinct heart sounds, regular rate and rhythm, normal rate, regular rhythm, no murmurs, with clear breath sounds, soft abdomen, but with diffuse direct tenderness, with no guarding or no rebound tenderness. He has no sensory motor deficits. So for his extremities, he has erythematous, palpable, non-blanching maculopapular rashes on both lower extremities, buttocks, upper extremities, and post-auricular areas, with bilateral slight knee joint swelling, with no warmth, but with limited range of motion on both elbows, knees, and ankles. No genital ulcers, no bipedal edema. And on DRE, he has good sphincter tone. Prostate was not enlarged, no palpable masses or fissures, but has bright red blood per examining finger. So I will be taking a pause now.
Yeah, Hans, could you just repeat the last sentence again? You said the fingers look, you said there's red spots or
On
something.
DRE, there's a bright red blood per examining finger.
Oh, gotcha.
Yeah.
Digital rectal exam. Gotcha. Yeah. Mm.
Is it my turn to start?
Yeah, feel free to go ahead.
Yeah. I think I'm gonna go analyze the exam in reverse. I'm gonna start with the skin because that will be the most like triggering thing. I think I'll see initially when I examine the patient, and then I can comment on the abdominal pain. In general, the rash is non-blanching, which that tells me that this could be in relation something that's affecting the vessel integrity. This could be something like a vasculitis or a like for example, Rocky Mountain spotted fever could cause a non-blanching rash. And we had a VMR last week where we discussed palpable versus non-palpable purpura and the significance of that as well, how each one can throw us towards a different diagnostic pathway as well. And limited motion of the elbows. This I was thinking is related to infiltration, but this could also be related to the vasculitis, or if there is a bleeding tendency, this could also affect the joint if they're having a hemarthrosis, for example. I also learned recently, or was reminded recently, that if we differentiate between petechiae or bigger hematomas, that can help us differentiate between a platelet disorder or a clotting cascade disorder. Although I don't think that's necessarily at play here, given like the hyperacuity of it. I think the diffuse tenderness on abdominal exam goes with the history, which we predicted or we expected in Raynaud's syndrome. So in general, in my mind, this is looking a lot like a classic like IgA vasculitis case, but I would obviously want to rule out the mimickers, which include like systemic infections and like less likely a primary GI disorder that's having like a systemic fingerprint. What are your thoughts, Mengyu?
Yeah, that's great analysis of the rash. I agree. It's being non-blenching, it points us towards like petechiae or purpura, and then with being a palpable points towards vasculitis, kind of the thrombotic nature rather than bleeding. So, I kind of take a little bit step back to the first aliquot to connect with the history. I think initially, I think with the sore throat, I thought we should at least rule out systemic, in a young patient, at least rule out systemic infections like HIV. I thought about syphilis, but usually syphilis have more like lymphadenopathy that you would definitely think about that, or if with fever. So maybe less likely so, but might still, get a sexual history, which could also be associated with reactive arthritis. But I think joint pain and fever, sorry, not joint pain and fever, joint pain and rash, the combination is a very interesting combination and can have several associations with, and that has like a viral or viral, could be like infectious viral or autoimmune, a lot of autoimmune diseases. And I think we're thinking less likely in the realm of malignancy or cancer here, being given the acute course in the young patient. So we're kind of focusing on infection and autoimmune, but with the GI tract, I think less likely about an infection other than if it's like preceding reactive arthritis. Like if it's a preceding event triggering an autoimmune disease, then I would think about. Otherwise, I think other than getting HIV and syphilis at most, but I wouldn't, and even gonorrhea. But I think again with the GI tract involved, and I think less likely in that realm. So I kind of focusing on the few autoimmune diseases that we look at. I think the rash will give us a lot of clue, like in terms of the nature, whether it's like IgA associated vasculitis, which could be like leukocytoclastic, or I think IBD is another consideration in a young patient with abdominal pain and a GI bleed and joint and rash. Even though the rash, I feel like is a little bit atypical, because for IBD, the rash you would most commonly is kind of a pyoderma gangrenosum or like a pustular PG pattern. So petechiae is something I heard less in IBD or Crohn's disease. So I think again, then more focusing on the IgA vasculitis assumption here. But I'm curious to hear more about the lab. Did I miss anything else you kind of discuss, Youssef?
No, I really like all of your thoughts. This was what I was thinking as well. And I want the HIV like you mentioned, but if we're thinking of acute HIV, I would want like an RNA instead of like a antibody, because if it's like an acute episode, if it's within the first 12 days, the antigen antibody would not be as sensitive / specific.
Yeah. And like Ravi also commented in the chat, there's of course other skin findings in IBD, like E. nodosum, equidermatitis enteropathica. Yeah, and so I look forward to reading more about that. But I think just purpura is not something I see very common in IBD. But yeah, I look forward to your next aliquot, Hans.
Okay, so before I proceed with the next aliquot, I'd just like to answer one of the questions. The patient has no sexual history and no history of illicit drug use or IV drug use. So for the next aliquot, the patient has an hemoglobin of 15 grams per deciliter, which decreased during the hospital course up to 10.9. WBC of 8,810 with 77% neutrophils, 13% lymphocytes, 9% monocytes, and 1% eosinophils. His platelet count was also normal, 299,000. His sodium was slightly decreased, 134.1, potassium 4.1, BUN 3.69, creatinine was also normal, 81.14 micromole per liter, AST is 16, ALT is 19, uric acid of 304, total cholesterol of 3.13, amylase normal 48.5, lipase normal 24.4, LDH was normal 219, and slightly elevated INR of 1.17, slightly elevated prothrombin time 14.1 seconds, and slightly elevated PTT 32.4 seconds. On his stool examination, RBC was more than 50 per HPF, and no ova or parasites were seen. WBC 0 to 2 per HPF. I will be taking a pause here.
Yeah, thank you, Hans. I think I'll take this my turn to take this aliquot first. So in reviewing the labs, I think first noticing that it's platelet count is normal. I think again confirming the rash, the purpura is not due to bleeding, just correlating with the palpable nature of the exam. And sorry, Hans, you said the hemoglobin at first was 15 or
15,
drawing,
yes.
but dropped to 10.9
10.9.
at a okay, at a second check. So that correlates with the bleeding. It looks like a pretty significant bleeding, unless the first one was like hemo concentrated. And then on the chemistry, it sounds like the creatinine is normal, right? Like there's no kidney involvement at this time. Yeah, so I think that's good to know, because I know IgA vasculitis could definitely involve the renal, but sometimes it's not always, doesn't always involve the kidney, and could happen at a later time during the course. So I think just keep watching the kidney would be important if we're considering systemic autoimmune pathology. And then uric acid seems pretty high for me here. What is the normal range?
It's actually normal.
Oh, the
300,
normal.
yeah.
Gotcha. Good to know. Yeah. Because otherwise I would be wondering if there's some, again, we're not really thinking about cancer or tumor lysis, but if uric acid is high, or if there's a gout, I think also, but again, it's normal, then that's reassuring, not in that realm. INR, I guess, is mildly elevated. I'm a little bit unsure how to interpret this at this time. Could be like nuance. Maybe I'll like follow up on that, make sure it's not getting worse. Because so far I don't get a sense of anything like DIC or unless it's like a commonly like a vitamin K deficiency kind of etiology in the setting of the patient's acute illness or maybe GI involvement. Yeah, and maybe Youssef, you can share if you have additional thoughts or any thoughts on the stool studies in particular.
Yeah, I think before I like jump to studies, my reaction initially when I saw that the hemoglobin was high, I was worried like, oh, could this be? Are we gonna hear thrombocytopenia next? And is this gonna be like a case of dengue with hemoconcentration? But like you mentioned, I was like, oh, this could be hemoconcentration. Although, because in my mind, dengue typically causes the rash through the thrombocytopenia, so I was very reassured of that that's not contributing. I'm also from like a management perspective, I'm really wondering, oh, is this patient having an active GI bleed? Because in the hospital, that's going to be the first thing that I'm going to think of. How do we stop the bleed, or how do we support this patient in order to stop this? So I'm trying to localize to the upper GI tract versus lower GI tract. I know they had like black stools, and on exam we saw some bright red for rectum. So like you're mentioning, I would want like serial hemoglobins, and potentially consult like gastroenterology to see if they would be eligible for like a endoscopy, colonoscopy, depending on the source of the bleeding and pending other imaging. I'm assured that the stool doesn't have any ova and parasites, and we see the right RBCs are positive, and this like reassures our exam. Mengyu, I just wanted to ask you a question. I know we're thinking of like IgA vasculitis, for example. Could this be like a first episode of cryoglobulinemia? I know this is I'm stretching the case here, but I'm just wondering if hypothetically, could this still be on the differential?
Yeah, that's a great question because with the rash, you would think about that condition. I often associate, I have to read more about cryoglobulinemia, but I often associate that with HCV or I'm sure there are primary maybe cryoglobulinemia, but I think getting HCV for sure, given the nature of the rash, to see if that's like an association. But yeah,
That was my thought too. That if it was more like chronic subacute, I would have thought of that. But because it's so hyperacute, I'm leaning towards towards IgA vasculitis. But I was just wondering, and hypothetically, does the MS script fit as well for a
yeah,
first
maybe,
episode?
yeah, maybe, and then RF as well, which will also help, and the complements I think also will help us move forward as well.
Yeah, because the other thing I would think of is doing supportive care, stopping the bleed. But from a diagnostic perspective, I would potentially want a skin biopsy, and then that could show us like the leukocytoclastic vasculitis versus the blood test, like you're mentioning. But I think stabilizing the GI bleed would be priority as well, because
Yeah.
we don't see any like flagrant abnormalities we can fix on the chemistries to help prevent the bleeding. I see the ANR is mildly elevated. I don't know if there's like a vitamin K deficiency as well. The other thing I would think of is, could this be like could there be something in the abdomen we're missing? So I would also want abdominal imaging. I know like it's associated with intussusception, for example, and things like that.
Yeah, totally. I think at this point we're kind of gonna to need to talk about management and next step of workup. And I think I don't know what the vitals is here right now, but I think the initial vital seems reassuring that it's the bleeding is not like actively acute, although the hemoglobin is a little bit concerning. I think we'll have to kind of monitor the significance of the GI bleed and the hemoglobin count to kind of which will help the GI doctor decide on the next step, whether to go ahead and do a EGD. In the meantime, we'll probably start the patient on some PPI just empirically to cover any potential upper GI bleed. I think with the BU, I don't know if I have BUN here, which if elevated could also points more toward upper GI bleed. But otherwise, I think imaging will help. If it's image negative, then well, our differential will be, I mean, I think for GI bleed, you don't, unless you see something significant, like you don't always see on the, but I agree, I think it was with the abdominal pain, the patient probably had some imaging to rule out any significant causes. But I kind of agree, like next step includes like a skin biopsy to kind of tell us the underlying pathology. And blood work like IgA and yeah. Should we move to the next aliquot?
Okay, for the next aliquot, for the urinalysis, the specific gravity was 1.015. It was negative for protein, glucose, ketone, nitrite, but has trace blood, trace leukocytes. The RBC was 1 to 3 per HPF, WBC 2 to 3 per HPF with few bacteria. The dengue test was negative for NS1, IgM, and IgG. Typhoid test was also negative, IgG and IgM. The ASO titer was elevated, 569.1. The CRP was also elevated, more than 300 milligrams per liter. The ASR is also elevated, 16 millimeters per hour. The blood culture shows no growth, and the 12-lead ECG was normal. For the chest X-ray, it's normal. The whole abdominal ultrasound was also normal. The EGD done showed gastric vascular ectasia, duodenal ulcerations at the third portion of the duodenum. The colonoscopy was normal. The biopsy of the duodenal ulcer showed small intestinal mucosa with severe active inflammation and chronicity changes. reactive epithelial changes, no dysplasia, granulation tissue formation consistent with ulcer edge, and no granuloma. And MTB PCR of the ulcer was also negative, and H. pylori negative also. So I will be taking a pause.
Wow, what an interesting aliquot. What do you think, Youssef?
Yeah, thank you, Hans. We asked for an EGD and a colonoscopy, and we got both. So just going through the data we see on the UA, we see some trace blood and leukoesterase. I don't think I will put a lot of diagnostic momentum in that, especially that we're thinking, could this systemic like potential vasculitis be affecting the kidneys as well? And otherwise, I think the dengue serologies were negative, which is good as we expected. The ASO was positive. I think that can be associated with like a recent strep infection, but it's also doesn't necessarily reflect that. I know it can have like a false positive, but it could be reflecting the trigger potentially. If this could, the patient started with a sore throat, could this have been like a strep infection? It may be the case, but it's not necessarily that specific or sensitive, so I wouldn't put all my diagnostic momentum there. It's just like one extra clue. In regards to the ulceration on the duodenum, I'm not sure why the patient has the ectasias. I'm not sure that's the mechanism of bleeding in like IgA vasculitis. So I don't know if Mengyu, if you had any thoughts.
Yeah, so yeah, I agree with your analysis. I think so at first when you started mention, actually even before you mentioned about the UA, I was like, yeah, I think we learned in the prior VMRs that we should at least check a UA to make sure there's no renal involvement, even though the creatinine is normal. I think here the UA is not that convincing because there's no protein and only trace blood and Luke, which could be non-specific, but I would maybe trend it to make sure it's not developing some sort of glomerular disease, especially with the ASO elevated. I agree. I think it could be the patient had a recent strep infection, and I don't know if it's related to the recent sore throat that 5 days ago patient had, or maybe something happened in the past. Although with the strep throat not being treated, I don't know how come it is to actually resolve on its own, or maybe the patient still have that symptoms. Anyway, so but again, with the strep infection being feel like it could trigger a lot of the conditions, including autoimmune diseases, like including IgA vasculitis. And there's like also that associated with the glomerulonephritis for sure, but here we'll just watch for that. And then the EGD biopsy. So the inflammation, so it involves causes the ulceration or duodenum. I don't know if it's like more pertaining to just like the severe acute inflammation. It feels like it's related to this part of this syndrome, like a GI tract. I have to read a bit more, like what's the GI tract involvement of IgA vasculitis, but I assume it could be related to that. I wonder if there's any special staining, for example, IgA or complement, to see if it's along that pathology. But I think that's possible. Yeah.
Yeah, I agree. I know IgA vasculitis is associated with GI bleed. I'm not sure how the mechanism is on the EGD/colonoscopy. And the other thing that I wanted to mention is that I would also want blood cultures. I know these are like not mentioned like in the as a results, but endocarditis and bacteremia can be associated with leukocytoclastic vasculitis. So I would also want blood cultures as well up front, just to be sure we're not missing any like flagrant infection.
Yeah, and thank you, Hans, for putting the full report of the studies in the chat. I don't know how common it is to have a author, but oh yeah, go ahead, Hans. What did you say earlier?
I think it's Dr. Gerwal. Thank you. She's the one typing the.
Oh, gotcha. Oh yeah, MO. Yeah, thank you. Ooh.
Okay, so for the last aliquot, actually, this patient was admitted in hospital with limited diagnostic capabilities. So ideally, the rheumatoid factor, ANA, The ANCA serum complement should have been tested also, but was not unfortunately available in that hospital. And I would just like to share the differential diagnosis the attending came up with during the patient's admission. First, he considered dengue due to the presence of joint pain, rashes, abdominal pain, bleeding. But however, it was negative on the dengue test. Next is inflammatory bowel diseases due to the abdominal pain, hematochezia, and extraintestinal symptoms like joint pain and rashes. However, the patient has normal colonoscopy. And lastly, post-streptococcal reactive arthritis was also considered because of the arthritis following a pharyngeal infection without satisfying the Jones criteria for acute rheumatic fever. However, it cannot explain the patient's GI bleeding. So, this patient was then clinically diagnosed as IgA vasculitis or hinoxion line purpura with duodenal ulcer as a complication after satisfying the diagnostic criteria for HSP set by the American College of Rheumatology, which was described as the presence of palpable purpura or petechiae with lower limb predominance, plus one of the four criteria, including diffuse abdominal pain, histopathology showing IgA deposition, arthritis or arthralgia, and renal involvement of any hematuria or proteinuria. The patient actually has good urine output all throughout the admission. Skin biopsy was also not done after making this clinical diagnosis and after seeing the patient improve with steroids. First with IV methylprednisolone, followed by oral prednisone and supportive treatment. Though NSAIDs, which should have been effective for treating the joint pain, was avoided in this case because of the presence of the duodenal ulcer and the GI bleeding. And during the patient's follow-up, after starting on steroids for 2 weeks, he no longer reports any melena, hematochezia, no abdominal pain, and no joint pain. And the rashes also did not progress any further. And he was also able to ambulate normally now. So the final diagnosis was IgA vasculitis with duodenal ulcer.
Wow, thank you so much, Hans. I really love this case. It has such a rich differential diagnosis, and I'm glad the patient did really well with the clinical diagnosis and the treatment started promptly. That I think could also avoid any renal complications from this disease. Yeah, Youssef, do you have some reflections to share or comments?
No, I just wanted to say thank you, Hans, so much for the case. It's an amazing case. I don't think we necessarily needed the C3, C4 rheumatoid factor because like you mentioned, like IgA vasculitis can be diagnosed clinically and the treatment is supportive and you can see through the test of time, like you treated the patient and they got better. And that proves your diagnosis. And if it doesn't recur, that's how you know it's like, oh, you did that diagnosis correctly. So no, we were asking that like we were being extra, but I think the primary clinical diagnosis fit the criteria. So thank you so much for this like great case.
Yeah, I also love how the EGD shows like the ulceration as the presentation of a GI complication of vasculitis. I have to read more like what are the usual GI complications. Is it usually ulceration or something else? I know like the GI bleed, but I think knowing the underlying pathology is helpful for me to learn this disease as well. So yeah, thank you so much, Hans.
If we have time, I can also share some teaching points regarding this case.
Yeah, absolutely. I really look forward to it.
I'd just like to answer Dr. Rabi. This is from the Philippines. So usually this is a special case for me because when we see a patient with a joint pain, with bleeding and rashes, we usually just think of dengue because it's very common in our country. So seeing this case was very nice experience for me, especially it's pretty rare in its age group. So IgA vasculitis, formerly called as hinoxion line purpura or HSP, is a disease that causes the antibody IgA to collect in the small blood vessels, which then become inflamed and leak blood. And it can be triggered by infections, most commonly upper respiratory tract infection, including streptococcal pharyngitis, by drugs, malignancy, autoimmune diseases, and possibly vaccination. And nearly all people develop a red or purple rash. Some people also develop problems with their GI tract, joints, and kidneys. It's most common in young children, actually, between ages 4 and 7, but people of all ages can be affected. Most patients recover spontaneously without treatment, but short courses of NSAIDs may be used for the joint pain, and corticosteroids are indicated in the following. First, if the patient has severe abdominal pain or GI bleeding, persistent nephrotic syndrome, crescents in more than 50% of the glomeruli, severe scrotal edema, and rare severe manifestations like CNS vasculitis and pulmonary hemorrhage. And immunosuppressive medications including cyclophosphamide, cyclosporine, azathioprine, and mycophenolate mofetil have been also used to treat glomerulonephritis due to IgA vasculitis.
Thank you so much, Hans. Yeah, we learned so much from you. I have to also reflect more about this condition. Like, I'm sure there are a lot of interesting knowledge and details to learn. I realize I don't have a robust note in my external brain on this condition, even though I've learned it in the past. So I'm looking forward to reading more. Yeah, I think anything else, Lokesh, before we hear Shreya's excellent teaching points? Awesome. Yeah, Shreya, it's all yours. Look forward to your teaching points. Yeah.
Sure. Thanks, Hans, for bringing this wonderful case. So we started off with a 21-year-old male patient who presented with black stools and abdominal pain. And the general framework which we take for black stools is we think of some GI bleed or, for that matter, any condition where the patient can swallow blood and it can react with the acid in the stomach and ultimately produce that particular discoloration. So we can trace the bleeding from any source, starting from the upper GI tract or even the from the nasal mucosa, and any kind of swallowing which can ultimately react with the acid can also lead to black color stools. And in CP solvers, whenever we think of a young person presenting with a particular illness, we think of three main things. We think of things which can be bad genes or bad luck or any type of risky behavior. So that's a general framework which you can apply for a young patient who's presenting with an illness which we cannot readily explain. And Mengyu also mentioned that in a person with GI symptoms, especially a young person, it's very important to first rule out any life-threatening causes like obstruction and perforation. And so as the case progressed, we noticed that the patient first had an upper respiratory tract infection a week prior to his presentation, which then he later also had joint pains, and then the rash came about. And much after that, he started having the GI bleed, which was his current presentation. So this kind of a pattern makes us think more along the lines of a systemic process. And so we were entertaining the possibilities of a vasculitis like IgA vasculitis, and Dr. Youssef also mentioned that could also be cryoglobulinemia, could also explain the palpebral purpura, the arthralgias, and the weakness in the patient. So that's one of the triad which we generally see in cryoglobulinemia. So that was a very interesting thought. And but then not to anchor in on any particular immunological condition, we also entertained the possibilities of a disseminated infection. We were also thinking along the lines of dengue, because from where the patient comes, it's endemic to that particular part of the world. So we need to really think about dengue as well. And also reaction to an infection, vasculitis, as I've mentioned earlier, and also malignancy are some of the things which we try to rule out. And also, Mengyu also mentioned in a young person who's presenting with fever, sore throat, and a disseminated rash, it's really important to rule out sexually transmitted infections, especially acute HIV. And when we think about sexually transmitted infections, it's also important to rule out other sexually transmitted infections as well. And you also mentioned that for when we consider the diagnosis of acute HIV, it's more important to think about HIV RNA is a much better test, because we can escape that particular window period and help patients receive a diagnosis earlier. And then as the case progressed, we came to know that the patient had a non-blanching palpable rash, and it's always useful to get a characterization of the rash. So this was the nature of the rash. And so we kind of realized that it was more of a process which was affecting the vessels, but then we still waited to get the complete blood picture to make sure that the purpuric rash was not due to thrombocytopenia. And so that's exactly what we got in the next aliquot, a purpuric rash with a normal platelet count. So that makes thrombocytopenia and dengue fever and all the arboviral infections, which bring the platelet counts down much lesser probability, and helped us to prioritize pathology in the vessel. And at this point, we were also thinking that a rash, we were thinking about what investigations we'd like to get next. And so we also mentioned that rash, along with the GI bleed and abdominal pain, especially post-viral infection, is also concerning for intussusception. So some sort of abdominal imaging would really help to rule out that intussusception. So ultrasound of the abdomen and imaging was obtained, which ruled out
Yeah, wow, Shreyas, that's amazing. Thank you so much for your teaching point. That's like absolutely on fire. Also, like the chats, I learned so much from the chats. I need to catch up, and I like all the points people shared in the chat. So thank you for everyone's participation, and thank you again, Hans. And hope you have and thanks, Jia, for your wonderful scribing. So hope everyone have a good day and see you tomorrow. Bye.
Guys.